Hi, everyone, and welcome to today's Pulmonary Fibrosis Foundation Disease Education webinar series. Today, we're holding an Ask a Doc question and answer session, including myself. I'm Dave Lederer, I'm a pulmonologist at Columbia University in New York and a Pulmonary Fibrosis Foundation Senior Medical Advisor. On this webinar, we also have Dr. Gregory Cosgrove from National Jewish Health, who is the Chief Medical Officer of the Foundation. Welcome, Greg.
Thank you, Dave. Glad to be here.
And we also have Dr. Danielle Antin-Ozerkis, who's the Clinical Director of the Yale Interstitial Lung Disease Program in New Haven, Connecticut. Welcome, Danielle.
Thanks. It's great to be here.
So before we begin, I want to make a disclaimer for everyone, which is that it's very important that you take the information that we give you and you take it back to your doctor or your healthcare provider and talk about it. No one on this webinar should be making changes to their medical care, the medications they're taking, or anything else based on the information we give you. This is just information. We're not making medical recommendations or providing any medical advice. We have come up with many questions that we receive from you through our Patient Communication Center and during the registration period for this webinar. There's also a question box on your screen, and you're welcome to type in your own questions, and we will either answer them back to you confidentially, or we will discuss them as part of the webinar. So I'm going to start with this slide. And these are very common questions we receive, very important because this can be a confusing family of diseases. I'll read the first one. What is the difference between interstitial lung disease and pulmonary fibrosis? My doctor has used both of these phrases in reference to my condition. So Greg, do you want to try to tackle that one for us?
Sure. This is a phenomenal question that's brought up every day. And the way in which I handle it when patients ask me is, number one, I acknowledge I think we do use those terms interchangeably, and I don't believe it's necessarily as accurate as it could be. So interstitial lung disease, the way I describe it, is a broad group of diseases. And under that umbrella of 180 or so different lung diseases, those diseases that cause pulmonary fibrosis are housed. But there are other interstitial lung diseases that may not result in pulmonary fibrosis or lung scarring, but might be limited to more inflammatory diseases. And so while it's in general referring to your lung disease as an interstitial lung disease, I would not necessarily assume that you have I think when people say pulmonary fibrosis, oftentimes they are referring to the sets of diseases that cause permanent scarring of the lung. And so there's a difference in my mind. I try to be as specific as possible. And that's one of the challenges we have in clinic is when someone has an interstitial lung disease, trying to define which one of the different diseases they have, and it maybe alludes to the next question, because depending on which interstitial lung disease one has, the prognosis may be different, the reason one has it may be different, and oftentimes is, and that leads to perhaps different therapies. And so the best example I have is in someone who has interstitial lung disease from an exposure like perhaps a work-related exposure or home exposure. Commonly, perhaps they have a pet bird. If they develop an immune reaction to that bird and have chronic or have hypersensitivity pneumonitis, which the treatment for that would be to remove the exposure, and they may not go on to develop permanent pulmonary fibrosis if we remove the exposure up front. And so I think that really sets an example in my mind that the global term interstitial lung disease can be separated from those with pulmonary fibrosis, but they are uniquely interrelated. And it is very common for doctors to use the terms to signify the same disease in one patient. And Dave and Danielle, I don't know if you want to have additions to that, or hopefully no corrections.
No corrections. I agree. I think the thing that gets confusing is that when people see pulmonary fibrosis, and when you look that up on the internet, what you really find is you find information about idiopathic pulmonary fibrosis, and that's actually just one subtype of interstitial lung disease. And what we do in the office is we really try to figure out, is that the diagnosis that somebody has? And the way we do that, and this kind of goes into the next part of the question, is we try to figure out, can we find any kind of cause for the lung disease? And then what kind of pattern do we see on the CAT scan? And if we do any kind of biopsy of the lungs, what kind of pattern do we see there? I can go on a little bit more about the later question if that would be helpful.
Yeah, please. That's about the difference between usual interstitial pneumonia and IPF, please. Thanks.
Yeah, so when I meet a patient, I'm really trying to figure out, do they have idiopathic pulmonary fibrosis or do they have some other form of lung disease? And so the first part, as Greg was talking about, is we try to figure out, is there a cause for the lung disease? And part of it is looking for exposures, things like birds in the home, feathers, problems with mold, water damage, that kind of thing. And also looking for immune diseases, things like rheumatoid arthritis, something called scleroderma. There are all kinds of immune diseases that can cause pulmonary fibrosis. If we can't find any cause whatsoever, we call it idiopathic. But then to call something idiopathic pulmonary fibrosis, we actually need both that lack of a cause and also a very typical CAT scan. And so that's where that usual interstitial pneumonia or usual interstitial pneumonitis pattern comes in. That's something that we have defined a certain way based on what we see on the CAT scan. So the UIP pattern on a CAT scan, it involves the lower parts of the lung, it's the edges of the lung more than the center. There shouldn't be inflammation in the lung that we can see on the CAT scan, and there should be cysts, something called honeycomb cysts on the CAT scan. And if we see that whole pattern and no other features that make us worry about some other form of disease, then that's what we call that UIP or usual interstitial pneumonitis pattern. And if we see that, we often don't need to go on for a biopsy at all, unless there's something really unusual. But in somebody who has a CAT scan that isn't completely classic, sometimes there is a biopsy. And when we look at it under the microscope, there's also a UIP pattern under the microscope that has been defined a very specific way. The thing that is important is that sometimes people get a diagnosis of that UIP, but you can see that pattern in other diseases. So it's really important to make sure, for example, that somebody doesn't have rheumatoid arthritis, because you can see UIP with rheumatoid arthritis. And so it's important to separate it out from IPF.
Yeah, I wish I had something to add, but you two, that was really fantastic information about both of these key questions. So why don't we move on to the next question, which is about elevation and climate and how they affect people with pulmonary fibrosis, and whether there are certain geographic regions or climates that are better suited for patients with a diagnosis of ILD. So I think we can split this up into two questions. One is about climate and one is about elevation. And I'm going to take the prerogative to take the easy one, which is elevation, and then ask you guys about climate. So as many people, but not all people know, as you go to greater elevation, so rising up to a city that's high above sea level, like Denver, where Dr. Cosgrove practices, or climbing up a mountain, as you move farther and farther up from sea level, there's less oxygen that you can breathe in. So people with lung disease who live at altitude or who travel to altitude can have serious problems with their breathing, being much more breathless, having lower oxygen levels, being more limited in what they can do, and often are miserable and wish they didn't make the trip. So elevation is very important. So do one of you want to address the climate question? And this certainly comes up a lot in my clinical practice. Either of you?
Well, I mean, this is an easy question in that I don't think anybody really knows. I think it really depends on what the patient feels best. I find some patients are really more comfortable when the weather's warm and humid, and others are miserable and they need the air conditioning on nonstop. Sometimes people suffer through the cold and other people are completely happy. I'm not aware that there's actually a specific thing that's better for any one patient.
Me, same here.
That's
really
my
common
experience
question
as well.
Yeah.
The one thing I might add being, I see patients and the issue of altitude comes up every clinic, is that yes, it is important to think about before traveling and be proactive, and that if someone is not on oxygen at sea level, discussing travel to altitude with your physician to assess if you would need oxygen when going to higher altitude. And there are ways to assess for that with an altitude simulation test if it's a very important trip, so that you can be supported when you come to altitude, rather than sometimes what happens, patients arrive at the airport here in Denver, and as Dave suggested, there's a marked increase in symptoms, which really is can limit the enjoyment of any trip. So just as occurs with any other disease process, thinking about travel and making sure you're prepared so that you can be proactive rather than responsive. An ER visit is never an adequate way to spend your vacation.
I totally agree. I think that travel is something that people worry about or they don't realize, and then they don't plan for. But actually, being in the airplane is the equivalent of being at some altitude. The cabins are not pressurized to sea level, and so sometimes people will need oxygen just with flight alone, even if they're not going to a place where they have a higher elevation. And so planning for something like that is really important and can make the trip a better thing. But every airline is a little different. There's different forms. You need to have testing ahead of time. So it's really important to think about before the trip comes up.
Yeah, all great points. Why don't we go ahead and move on? We're going to talk about the causes of pulmonary fibrosis. And I actually want to start with a question from one of our listeners. I'm going to try to summarize the question, which has to do with a condition called hypersensitivity pneumonitis, which was mentioned already, and it's a type of interstitial lung disease that's due to exposure to something we're breathing in, and that could be mold exposure or birds or many other things. And the question is, if you get rid of that exposure, does the disease stop? Does it not progress, and could it even get better? Greg, do you want to address that?
Sure. I think it's a great question, and I would say it emphasizes the importance of really pinpointing the diagnosis. And it's just to clarify, it's not necessarily an allergy to mold, or we'll use birds as an example. It's some different immune reaction that occurs and often occurs after years of exposure to, if you have a pet bird in the home or mold in the house and such. And the body begins to react differently to that inhaled protein. And the injury that occurs can be acute, meaning you really notice and you might be blamed that you had a cold, so acute onset of symptoms, or the symptoms are slowly progressive over months. And the goal is to, as with any type of lung injury, is to limit the degree of injury, and if caught early enough, and this is the one time I do use the word cure, if we catch it early enough and remove the exposure, if we can identify it, which is an important issue sometimes, then the damage that occurs in the lung can be limited. The lung can recover to some degree, and we can avoid potentially permanent scarring of the lung. I would say that the vast majority of patients we don't catch early enough because the symptoms can be very subtle, but we can prevent overwhelming injury of the lung, and patients can go on to prevent progressive destruction of the lung. And so we kind of stop it in our tracks is how I would define a cure. And it doesn't progress in contrast to other scarring lung diseases. The one concern is that if we don't catch it early, it can develop a life of its own, even if we remove the exposure within. That's a feature we've seen in certain patients. And so it emphasizes the importance of thinking about the diagnosis and appropriately removing an exposure if you believe it's linked to the lung disease. Now, a caveat is I always get asked, well, I have a bird, does that mean I'm going to develop hypersensitivity pneumonitis? No, it doesn't at all. What it means is that if you have symptoms and you have a concerning exposure, we should look at that and make sure that the two aren't linked. But just because one has a bird, it's important to realize that they're not going to develop hypersensitivity. That's one of the lack of understandings we have about the disease, because we don't understand why certain people get the disease and other people don't, even though they have the same exposures. So hopefully that answers your question appropriately. I don't know if I missed anything, David, Danielle.
Yeah, I think that was great. I do want to say we are getting a lot of fantastic questions in here. If I'm not answering your question, it means I'm saving it for later when we come to the topic that you've asked the question about. So I am going to try to get to everyone's question. For now, let's talk about the question on the slide here, which is, does reflux or heartburn, this is acid reflux, cause pulmonary fibrosis? And we could do a whole hour on this. I think we might have done a whole hour on this a few years ago in a webinar. It's a very common question. A lot of people with pulmonary fibrosis either have heartburn symptoms or actually have asymptomatic heartburn, meaning they have it, but asymptomatic reflux, meaning they have reflux, but they don't have the symptoms of it. They don't have pain. And I'll maybe address this a little bit, which is that there is a link, as I mentioned, between the two. It's still not clear whether reflux might cause pulmonary fibrosis. The thinking is that if there's acid and enzymes and food in the stomach, if you're having reflux and those things are moving up into your esophagus, which is your food pipe, and getting all the way up into the throat, maybe they're dripping down into the lungs and causing injury and scarring in the lungs. And there is some evidence. Some studies have suggested that reflux or heartburn might be a cause of pulmonary fibrosis. And there's even a research study where some investigators surgically fixed the reflux in some of patients with pulmonary fibrosis and didn't surgically fix the reflux in others. And we're still trying to figure out what the results mean, but there were small differences. With the people who had the surgery seemed to do a little bit better, but it's hard to make any really firm conclusions from that study. So I think we don't yet know. Danielle, do you have a perspective on this?
No, I think you summed it up really well. I think there's a lot of concern that there could be a relationship because of that mechanism where, you know, if stomach contents were to go down into the lungs, that could set up an injury pattern and really cause it. But nobody's really sure exactly what to do about it. And that the study you were mentioning, the RAP IPF study was a small study, and I don't think it's given us definitive information. But then there's definitely a suggestion that we should be looking at this more. I think that there are things that people can do that to treat reflux in a way that I think is fairly safe and uncontroversial, which is you can try to do things like avoiding eating late at night, right before you go to bed, so that you're not lying down with a full stomach. Some people actually sleep with the head of their bed up at 30 degrees. There's like wedges that are sold at medical supplies if reflux is a significant problem. And those things aren't going to be quite as invasive as a surgery, but certainly have the theoretical possibility of helping, but we really just don't know enough to be able to recommend one thing over another right now.
Yeah, thanks for that. Jury's still out. Maybe next year when we do another webinar, we'll have more information. I guess we'll see. The next question,
Dave, this is Greg.
Yeah, go ahead,
I would
Greg.
just comment. I think this is an important issue, and I agree with everything that's been said. And this emphasizes your comments at the beginning of the presentation. Is this would be something that I would certainly talk to your provider about to understand their perspective, since there's no clear-cut right or wrong way, but it really needs to be considered in the overall context of care. So I think it's always a good thing to discuss with your physician, to have a team approach to your care as a patient.
And one other thing I might add that we'll probably get to a little later as well is if somebody has a really bad cough, I will go a little bit further looking for reflux as a potential cause for that cough. And that might be a little separate from the basic question of does reflux cause the pulmonary fibrosis itself?
Yeah, that's great. I do that as well. Yeah. Let's move on to the next question. Also a very tough one, and it's about genetics. So what is the role of genetics, and are there genetic tests that are available? So I don't know. I'm happy to start this one unless one of you want to jump in. This is always a tricky one. So let me start out by talking about genetics of pulmonary fibrosis. So the first thing to know is that almost every single disease is genetic in some way. That is, your body, the way your body is made, and your DNA that makes your body, sets up your body for different diseases. So you might have a low risk for one disease, but a higher risk for another disease. And sometimes a disease is 100% due to a gene. For example, a different lung disease called cystic fibrosis. Actually, it's not just the lungs, it affects someone's whole body. But cystic fibrosis is really determined by a single gene. Another example is sickle cell disease, which is a blood disorder, also determined by pretty much a single gene. But most diseases are not determined by a single gene. Most diseases are caused by multiple genes that you happen to have inherited, plus other things in your life or in your environment that contribute to the disease. And sometimes we as doctors can figure this out, which genes are involved or what are the things in your environment that are involved. And sometimes we can't. Now, there are some forms of pulmonary, and so that kind of scenario where it's lots of different things, your bunch of genes, the environment you live in, that's the most common scenario in pulmonary fibrosis. But there are also some forms of pulmonary fibrosis where there are very strong genes that push the disease forward and put you at very high risk for the disease. About 30 or 40% of people with IPF will have an abnormal gene or an abnormality in a gene that has a funny name. It's called MUC5B, that's B as in boy, or MUC5B. And if you have the abnormal form of that gene, you're at increased risk for pulmonary fibrosis. The weird thing is that among healthy people, like 10% also have this abnormal gene. So just having that gene that's abnormal can't really tell you if you're going to have the disease or whether you have the disease. And there are other genes that are less common than 30%, much less common, that can also influence your risk of pulmonary fibrosis. But even people with any of those genes, not 100% of them get the disease. So again, just to give you those three pictures, on one extreme, things like sickle cell disease and cystic fibrosis, one gene, one disease. On the other extreme, lots of genes and lots of things that you might be exposed to throughout your lifetime causing the disease, which is true for most diseases like heart disease and other things. And then in between is that last category of diseases where a gene puts you at very high risk for the disease, but doesn't isn't the only factor, that there are other factors involved. And there are genetic tests that are available. Many of them are available only in research centers, like, for example, many Pulmonary Fibrosis Foundation care centers around the United States have the availability of research genetic testing. But there are some genetic tests that are available for clinical use, meaning that any doctor could order it. The value and usefulness of those tests has not yet been determined. For example, if the test is abnormal, what does that mean, right? Currently, it may not mean we treat you differently with medications. We are learning more and more about that. Maybe pretty soon it will inform how we treat you with medications. The big question, and probably something that all of you are thinking right now, is, are my children going to get it? Are my grandchildren going to get it? Are my brothers and sisters going to get it? And in most cases, even doing a genetic test may not tell you about that. Remember that 30% gene and 10% of healthy people have it. We don't have that test available, but if we did, and we tested your brother or your child and they had the gene, doesn't mean they're going to get the disease. So we haven't figured all of this out about what is the value of these genetic tests for an individual patient or an individual family. There are some people in some families where it is important to do genetic testing, and there are many families or individuals with this disease where it really is not important or would not be helpful. So I know that was a little bit long, but Danielle or Greg, do you want to comment on that?
This is Greg. I thought you did a great job, Dave. One thing I might add to it is what you underscored was the complexity of considering testing. And I would advocate that if anyone is considering that with their physician, it's the appropriate opportunity to get a genetic counselor involved, because ordering the test is the easiest part of the process. Actually understanding what the information may provide, and frankly, the risks of acquiring the test, because it can influence different aspects of one's care. And oftentimes, while medical insurance is protected by Genetic Information Act, personal health insurance is not. And so it's a bit more complicated than many people realize. And so we at the foundation have set up a genetic counseling line for individuals to at least begin to get a little bit more information, and by a certified genetic counselor, Janet Talbert. And so that is a resource that you can get a little bit more information moving forward. And several centers have the capacity for certified genetic counselors, which are great resources, but oftentimes they're not readily available in more remote areas. And so that may be an opportunity to get a bit more information for people that are interested.
Yeah, thanks for that, Danielle.
That's exactly what I was going to say. I think that if testing is going to be done, I think the role of genetic counseling is so important, and I'm really glad that was raised.
Yeah, I agree. Okay, let's move on to management, and maybe we'll start with this question, which is about antifibrotic therapies. And just so everyone, all the listeners, know what we mean when we say antifibrotic, so there are 2 drugs that are approved by the FDA and also approved and available in many countries outside the US to treat idiopathic pulmonary fibrosis. They are pirfenidone and nintedanib, and they go by brand names of Esbriet and Ofev. And we often refer to them as antifibrotics because we treat scarring in the lungs with these medications. And both drugs seem to slow the progression of IPF, of idiopathic pulmonary fibrosis. But importantly, and this will kind of preface the answer to this question, importantly, neither drug improves lung function. Neither drug seems to get rid of the scar tissue. Again, each of them slow the disease down. So the question is, are the antifibrotic therapies only stage appropriate, meaning based on severity of the disease, or is it, quote, sooner the better, end quote, when it comes to starting these medications? So good question, comes up a lot in practice and amongst discussion among doctors who take care of patients with PF. Danielle, do you have a perspective on this?
Sure. Well, so I think that in general, I think it is reasonable when somebody is first diagnosed with IPF, and just to be clear, the drugs are only currently approved for IPF, not for the other forms of pulmonary fibrosis that exist. I think it is absolutely reasonable to have a discussion and talk about using one of those medications at the beginning when the diagnosis is made, because when the question really comes up, are we doing better if we start earlier? The answer is probably yes. If you were to get at the fibrosis as it's in its early stages, you might be preserving lung function earlier. And now that we have longer and longer time observing patients who've been receiving some of these drugs, it seems that that is true, that people may be living longer as they're on the drugs for longer. So you can imagine that slowing down the fibrosis earlier might lengthen somebody's life, might prevent them needing oxygen for exercise for a longer period of time. So I think it's worth having the discussion. And the challenge is often that people usually when they're early in their disease often feel quite good. And so it's the kind of thing where it's similar to taking a medication for blood pressure, where you might not necessarily feel the effect of taking the medication, but it might actually be preventing something down the line. And it's hard to sometimes to say that you're going to take a medication that might have some side effects, and you can't really tell exactly how well it's working, because what we know about these drugs is that even the patients who got the drug in the trials, their lung function did go down, it just went down slower. And so it's really hard to know how well it's working in you once you've started the drug. And so you have to take it on faith a little bit once you've started. That all being said, it's still probably worth having that discussion, but it's definitely an individual discussion between each patient and their physician about the pros and cons of starting a medication, what their other diseases are, because there are certain things where you really have to consider, can you take a certain medication in combination with the medications you're already on? It's definitely an individualized discussion.
Yeah, I totally agree with everything you said there, Danielle. Greg, anything to add?
I might just add, it's a wonderful opportunity to emphasize what's called shared decision making, so that it's not a right or wrong decision, as Danielle suggests, but it's a discussion to understand what a patient's goals are, what their tolerance is for potential side effects. And so when I'm considering or when I'm discussing therapy with patients, those are really the key points that we want to bring up, so that we have the best decision for that patient, as Danielle suggests, and I avoid that right or wrong decision, because it really is a shared decision as the provider trying to optimize the treatment of progressive lung disease, and the patient optimizing what their goals are. And if they're very risk averse in terms of side effects, they may not choose therapy at this point, but that's why a serial evaluation allows you to understand their thinking in the future, and depending on how the disease is progressing, and you can bring it up, may not be at this point in time, but we'll address it in 6 months, and perhaps the decision will be different than the initial discussion. So I think we should have that regardless of what the disease is, but focus on that for each and every opportunity to treat patients.
Yeah, that's excellent. Well, let's keep moving. We're going to stick with management, and then again, folks, there's a bunch of questions here, some of which I've answered privately, but if I haven't answered it, again, we're going to get to it, I promise. Management, what are the latest findings about PF treatments in clinical trials, and what new treatments are being studied? I think we actually, when we answer this, we'll have answered about four questions that we've received. So latest findings, and I would say maybe we could think about the past year or so, year plus, and then new treatments that are under study. Yep, so there's been a few research studies suggesting availability of new treatments in the future. One we mentioned, which was the RAP study. That was the one where doctors did a surgical procedure to correct reflux. So we're all kind of trying to figure out what to do with that. But there have also been some early studies in the past couple of years on new treatments. One of them has a chemical name. It's GLPG 1690, and it's a drug made by a company called Galapagos, like the islands, Galapagos Islands. And it's a drug that's not FDA approved. It's not available by prescription. It is being studied. It was studied in a small clinical trial, what we call a phase 2 clinical trial, which is a kind of middle stage study where we're trying to see if there might be an effect. And there was some suggestion that it might work, and it's now being studied in a large, very large study that's occurring around the world. And it's specifically for people with idiopathic pulmonary fibrosis. And the drug inhibits an enzyme in the lungs. That enzyme has a funny name, which is autotaxin, like a car, auto, A-U-T-O, and then T-A-X-I-N. And there's information on the internet about this. You can also go to the Pulmonary Fibrosis Foundation's Clinical Trials Finder, which is on our website, to search for that trial and other trials that are ongoing. There's also a drug that has, again, a funny name called pamrevlimab, which inhibits a protein in the lungs called connective tissue growth factor. And we're still waiting for publication of those early phase or middle phase study, but it was presented a couple of years ago, and it looked like it might slow progression. And that's also going to be studied in a large study now. There have been some others as well. There's a drug called pentraxin 2. There's another called PBI 4050. So there are definitely things that have shown some promise in early phase studies. And then maybe I'll turn to Danielle and Greg and talk about some of the new treatments. I mentioned a couple that have built on the previous studies. Do you guys want to talk about maybe cleanup or other studies?
Well, one thing I wanted to actually mention was that a lot of what we're talking about is idiopathic pulmonary fibrosis, but I thought it was exciting that there was something called the Census trial that came out this year as well, which was looking at the nintedanib that we just discussed for IPF and looking at that in patients who have pulmonary fibrosis from scleroderma, which is a kind of autoimmune connective tissue disease. And so I was excited to see that other diseases are being studied, and also that there are some studies looking at outcomes that are really important to patients. So for example, inhaled cromolyn looking at cough for pulmonary fibrosis, which is a very important thing as well.
Yeah, thank you. Anything to add, Greg?
I would say that there are multiple products that are coming through phase 2 and phase 3, and I would add they all have apparently different mechanisms of action. So when I think about the future of pulmonary fibrosis, whether it's interacting with autotaxin or perhaps interacting with a particular molecule alpha V beta 6, which is a protein that appears to be important, and several companies have mediators that might block or inhibit that pathway. If it suggests that given the multiple different pathways that are being targeted, that pulmonary fibrosis has multiple different potential therapies, but the important part is exploring the efficacy or whether or not it works to block the development of fibrosis, and more importantly, the safety. And so it's important that we study them, but I would argue probably the single most important partner in proving that a therapy is as and safe are those in the audience or those that could participate and volunteer. So that we can talk about the trials, but unless volunteers help us, we'll really be at a standstill. So I would say that the successes we've had with the 2 approved therapies are attributed to the companies that brought those therapies. But I would say the major partner that allowed those therapies to be brought to treat patients are everyone that volunteered and participated in those studies and helped us prove that they're safe and helpful. So maybe that's a little bit of an altruistic statement, but I think it's incredibly true. So I'll thank you for those that participated and those that are considering.
I absolutely agree. I think it's an incredibly exciting time in research, and so many new trials are coming out, but we really need patients to participate and be willing to be part of it. And it's a great time to do that right now.
Yeah, thank you both for sharing those. Related to management, we have a question from one of our listeners, which is about treatment for pulmonary hypertension in people who have pulmonary fibrosis. And very wisely, the listener says, besides oxygen, because I think oxygen is one of the best treatments for pulmonary hypertension in people who have pulmonary fibrosis. I will say there was an early phase trial of an inhaled gas, inhaled nitric oxide, that seemed to maybe help people who have both conditions. I don't know if either of you have any thoughts or preferences or any thoughts about that question about treatment.
Well, as you mentioned, I think that a lot of times when people hear about pulmonary hypertension, they think about the medications, because when somebody has pulmonary hypertension, which is elevation of blood pressure within the lungs themselves, and it's something that can't be measured like with a blood pressure cuff on the arm. We can estimate those pressures with an echocardiogram and ultrasound of the heart. There are medications that can be used when somebody has pulmonary hypertension alone, but when somebody has pulmonary hypertension with pulmonary fibrosis, it becomes much more complicated, and that's where the controversy often comes up as to how best to treat people. But Dave, as you were talking about, some of the things that are the most important parts of it are some of the basic strategies, like making sure that somebody's oxygen levels are good. And that might involve testing somebody when they're walking around to see, do they need oxygen in that situation, but also nighttime testing. A lot of times people will have undiagnosed sleep apnea, or their oxygen levels might just go low while they sleep just because of the pulmonary fibrosis, and testing can be done, and nighttime either PAP machines or oxygen can be given, and that can really help in some ways before you get to talk about whether a medication would be appropriate or not.
That's really important, Danielle. I might add and just clarify what you mean by complicated. Patients who have mixed pulmonary hypertension and pulmonary fibrosis, the lungs' response to those combined disorders is to try to be as exquisitely efficient as possible to maximize how well the oxygen gets from the air sacs into the bloodstream. And some of the medications that we use to treat pulmonary hypertension that have been proven effective in the lone disorder can alter that enhanced efficiency in the lung. So theoretically, if we change that matching of the blood vessels and the air sacs and the efficiency of transfer of gas with the medications to treat pulmonary hypertension, we could actually make patients feel worse. And so that's the concern that maybe your physicians may have. At present, there is no approved therapy for patients with pulmonary fibrosis and underlying pulmonary hypertension, specifically in idiopathic pulmonary fibrosis. But the importance of those two diseases can't be understated, because as someone moves through the course of their disease, the incidence or the presence of pulmonary hypertension increases, such that almost 85 to 90% of patients who go on to receive a lung transplant, when they're studied pre-transplant, have the combined disorders. So it's an area of an intense interest, because we know that if we find an appropriate therapy that's safe and helpful, we could impact the lives of many individuals with pulmonary fibrosis. And it appears to occur independent if it's idiopathic pulmonary fibrosis, as well as in those with hypersensitivity. And it can occur in the connective tissue disease patients who have pulmonary fibrosis as well, like rheumatoid arthritis or polymyositis. So I'm glad to see we're moving forward to study it more effectively, but we just need more time.
Yeah, and there's it actually ties in nicely to a question we have from one of our listeners about clinical trials to treat forms of pulmonary fibrosis other than IPF. And the good news is that there is a lot of work being done in that area. The INBUILD study of nintedanib, which is OFEV, to treat a wide variety of fibrotic interstitial lung diseases. And then there are other studies of pirfenidone, which is Esbriet, to treat individual other diseases like hypersensitivity pneumonitis and rheumatoid arthritis and others. So fortunately, those studies are happening, and we're hopeful that within the next year, 2 years, 3 years, we begin to see some results, which will be exciting. Okay, let me see what we have next. Stem cells. So I'm glad we have time to talk about this. We had a couple of questions in the queue here about stem cells, and this is a big deal. So stem cell research, is there any progress for treatment? So Greg, I'm gonna really kind of defer this to you because you've really done a lot of, you've led a lot of kind of the advocacy work here, and maybe you want to address this for our listeners?
Certainly. I would say that there is, in the scientific community, the promise of stem cells is certainly recognized, meaning that the role of these unique cells to regenerate and perhaps repopulate damaged areas of the body is what led over the past several years for trials that to help patients with a variety of different diseases. That promise has not really come to fruition in terms of therapy that has been proven safe and proven efficacious beyond the hematologic malignancies. So patients who have certain forms of leukemia and then they receive stem cells as part of their treatment. When we think about stem cell therapy, which in itself is just an hour discussion of what I mean by that term, but when we think about perhaps coronary artery disease and patients who receive stem cells to heal a heart after a heart attack, or in our case, stem cells for the treatment of pulmonary fibrosis, there is no evidence at present and clinical trials that support that those therapies are helpful, and more importantly, that those, particularly for pulmonary fibrosis, that they're safe. And it's important given the tremendous explosion of for-profit stem cell centers that are advocating the use of these therapies without FDA approval and without evidence of safety. So because of this concern and what we considered targeting patients with pulmonary fibrosis, the Pulmonary Fibrosis Foundation, with its medical advisory board, put forth a cautionary statement to try to alert patients in 2015 in recommending that the use of stem cells should be limited to participation in clinical trials, which are ongoing, but they're early in their development. Because of the continued inappropriate suggestion that stem cell therapy is safe and effective for patients, over the past 4 years, we reissued the statement in March of this year, further cautioning patients. And so I'd encourage anyone, if you go to the Pulmonary Fibrosis Foundation website, we have a page that's dedicated to the stem cell statement, and there are 2 different statements. One is perhaps slightly more scientific, and the target audience was physicians and healthcare providers. And then we have a more or less scientific comment, which really addresses it from an advocacy standpoint. What I would say is that we remain encouraged, but encouraged that people in the community are organizing clinical trials. So Dr. Marilyn Glassberg at the University of Miami has actually had a phase 1 study, and then a colleague in Greece has had a phase 1 and early phase 2 study. And the questions they're trying to answer is the infusion of a stem cell product safe in a very small and select group of patients with IPF. And they also are looking at it, what if you inhale those cells into the lung? And so there are many questions that we have yet to answer in terms of what is the best route of administration, and if so, is that administration safe? And if so, does it actually help patients? Because one of the goals of any clinical study is first and foremost safety, but whether or not it works, because if it doesn't work, then we want to move to another treatment that has promise. And so I would encourage individuals to, number one, read the stem cell statement, discuss it with your physician, and caution those outside of a clinical study. I advise my patients, I'm very concerned about the use and infusion of those products in the absence of safety, evidence of safety, that they could cause significant harm. And there has been at least 3 NIH as well as FDA comments on this issue over the past several months. And so I think it's important for us to realize that it's still early in the phase, and I don't want to demean the promise, but we certainly need to make sure and evaluate these potential therapies appropriately to maximize safety first and foremost. So I might stop there. Danielle and Dave, see if you have comments.
Well, let me ask you to. So I mean, I think you covered all the key elements there. Let me ask you about something related, which has to do with supplements that people find on the internet that are not, FDA approved, don't have research behind them. Do you have any thoughts about that, Danielle? Does that come up in your practice with patients asking you about these things?
It comes up often that people, ultimately people want to have hope, and they want to take something that is promised to them that's going to make them better. But the problem with some of these things is that you don't know if that's the case with what you're getting. And a lot of these things, my concern is not so much that they might not help, but that they might actually hurt in some ways. We actually know that there are different kinds of lung diseases that can be caused by certain medications. And so, for example, when we're taking a history and trying to determine if somebody has idiopathic pulmonary fibrosis, one of the things we ask about is extra medications, over-the-counter supplements, because there are certain kinds of things that can actually cause lung fibrosis. And so I really worry about people getting things where we don't actually know what's in it, it's not regulated, and it could potentially cause harm.
Yeah, thanks for that. So I want to move us forward a little bit and talk about cough, which has been brought up a little bit already, and we have had a question about it in the queue here. And cough, actually 2 questions. Cough to me is a really tough one, and I find that a lot of the cough may not be the pulmonary fibrosis, and that by trying to look for other causes of cough, we can often maybe not get rid of it completely, but make it a little bit better. I mean, I treat a lot of, postnasal drip, GERD, as I think, Danielle, you brought up. So do you guys have any tricks for cough? And again, we're not going to make medical recommendations, but just give all the listeners some information.
This is Greg. I might just also put it in context, since cough is so common. When we queried about 600 patients in 2015 and said, tell us what the most common symptoms you have are, and tell us which symptoms limit you from doing the things that you like to do, like dancing or walking or playing with your grandchild. The most common limiting symptom was breathlessness. The second was surprising, and it was fatigue. But then I guess not surprising was cough, which is really difficult. So it is a common symptom, but maybe much less poorly understood. We kind of get if your oxygen's low, it kind of makes sense that you're breathless, but why do patients cough? And I worry the same as you, Dave, that are there additional causes in terms of chronic sinus disease or rhinitis or reflux? But intrinsic cough to pulmonary fibrosis, we don't know as much about why it occurs, but I'm very pleased to say that, as Danielle alluded to, that there is now a clinical trial looking at the role of an agent, cromolyn sodium, for the treatment of cough to decrease the intensity as well as frequency. We focus on the progression of the fibrosis, but I think it's also important to think about ways in which you can minimize the symptoms, which hopefully will impact the patient's quality of life, in addition to working on trying to increase the longevity of their life. So that's how I think about it.
Yeah. Danielle, anything to add?
No, I agree. I look for other causes for the cough, including there's certain medications like ACE inhibitors that can cause cough. And so it's important to just kind of think about the basics that way. But I think that cough is really tough, and I'm glad that there's a focus on it. There have been a few small trials. One was looking at thalidomide in the past, and then I'm interested in the cromolyn. Sometimes people will try gabapentin. Sometimes people will even try opiates. What I've actually heard from patients is that sometimes before it was recognized that they needed oxygen, they would cough a lot with exercise. And then once they received the oxygen and started using it with exercise, a lot of that cough went away. So that's also something to think about as well.
Yeah, I've definitely seen that a lot. Yeah. So we're gonna wind it up. I did want to maybe end with transplant, because there have been a few questions about transplant and prognosis, and whether transplant's the right thing. And maybe I will just raise a couple of points, and you guys can comment on it before we wrap things up. So, you know, lung transplantation is something we consider when the disease has progressed. And I should mention that for many people with forms of pulmonary fibrosis, the disease does progress over time. Everyone progresses in different ways, in different speeds. Some are very slow, sometimes very fast, and not always dependent on what your diagnosis is, but more specific to an individual. And it's hard often to predict what will happen. And because of that, and because transplant is kind of a last resort treatment, and we don't know how quickly the disease would progress, what I do with my patients and what current international guidelines recommend is that as soon as we identify that pulmonary fibrosis is the problem, that you should be referred for a lung transplant evaluation. And an evaluation is very different than going on the waiting list, or of course different than getting surgery. It's meeting with a transplant team and being considered for whether or not you should undergo, 50 different medical tests to see if you're ready for going on a waiting list. So the timing, which is the question here, is really now is the answer. Is if you haven't been evaluated or if you haven't been referred, you should be referred. If you weren't referred, there might be a good reason. Maybe you're not eligible for one reason or another. So I tried to tackle a little bit about prognosis and a little bit about transplant in there. Danielle, do you want to add anything?
Yeah, I mean, I agree with what you said. I do refer people early, and there's a few different things in why I do that. One is because we don't know what the speed of the progression is going to be in any individual person, but a lot of it has to do with just learning about the process and preparing for that possibility and really optimizing things to make it so that you'd be more successful as a candidate. So lung transplant is absolutely exchanging one disease for another. It's a very big deal and a lot to go through. And you really need to be essentially otherwise healthy as much as possible to get through a lung transplant. And so starting to do things like exercise, going to pulmonary rehab, starting to lose weight if you're overweight, improve your diet, get educated about the process in general and build up your support network, because it's really a group process going through a transplant. All these things are really important and require a lot of time up front. I do think that if it hasn't been discussed because somebody thought maybe they didn't meet a certain age requirement or something else, it's certainly worth at least talking with your doctor about, because many programs have changed criteria a little bit and it can be a little bit of a moving target that way. So it's important to have that discussion about the process.
Yeah, thanks for that. Any last minute comments from either of you?
This is Greg. I'd just like to say thank you for allowing me to participate, Dave. It's been great working with the both of you today.
Yeah, I'm glad you were both able to join. I do want to remind everyone that we have our next webinar in July, on July 17th. Greg Cosgrove on the webinar today will be hosting it, and joined by Anoop Nambiar, who's the ILD clinic director at the University of Texas Health Science Center at San Antonio. I also want to remind everyone that we have the Pulmonary Fibrosis Foundation Summit, also in San Antonio this November. You can go to our website to learn more, and I hope to see many of you there. And I also want to thank both of you, Danielle and Greg, for joining me, and our sponsors, Boehringer Ingelheim and Genentech. And for those of you who I wasn't able to get back to with a question, you can reach out to our Pulmonary Fibrosis Foundation Communication Center by emailing PCC, that's for Patient Communication Center, pcc@pulmonaryfibrosis.org. All right, thanks everyone, and we'll hope to see you in July.
Have a great day.
Thank you.